us to speak on a topic that is seldom covered. Uh, Especially postgraduates don't have much exposure to it, which is adjuvant chemotherapy. So more on that, but this has been possible only with the help of the Academy of Head and Neck Oncology of Karnataka, who've been helping us with all of the arrangements for this webinar. And the Academy of Head and Neck Oncology of Karnataka offers great support to budding head and neck oncologists in Karnataka. And anybody who wants to become a member should write to info@ahnok.com. Of course, this wasn't possible without the mentorship that we get from our senior colleagues, Dr. Ravi Nair, our Dean, Dr. Vishal Rao, and Dr. Akshay Kurpaje sir, who've laid the path for us to have this webinar. Also, our team here, Dr. Anand Subhash, my colleague, Dr. Bhargav, and Dr. Ritvi Bagadia have all been instrumental in making this webinar a possibility. So welcome everybody, and let's begin today's webinar. I want to introduce our moderator for today, Dr. Ratan Shetty. He was my senior while at Kidwai. He is an ENT surgeon who's finished his fellowship in head and neck surgery from Kidwai, and then later went on to do his MCH from Tata Memorial Hospital. Practiced there for a year, and now he is an assistant professor in the head and neck department at Kidwai. Welcome, Dr. Ratan. It's very nice.
Thank you for having me.
So, I hand over the session to you now to introduce our speaker for today.
Yeah, thank you. Let me introduce the speaker for today. Professor Govind Babu sir. I had the pleasure of working under him in Kidwai when I was doing my fellowship. My brother was also a student. And Professor Sir is right now working in SAG as a chief medical oncologist. Sir trained at Kidwai Memorial Institute of Oncology and also has trained in Dana-Farber Cancer Institute, Boston, and MD Anderson Cancer Institute, Texas. He did his DM Medical Oncology from Kidwai, and his special interests are in genomics and solid management of solid tumors and hemato-oncology. And Sir has numerous publications in various national and international journals, and is a lot of trials under his name. Yeah, I hand over the podium to you, sir.
So you will have to unmute yourself.
Yeah. Thank you, Ratan, for that nice introduction. I am not sure if I deserve a lot of it. Anyway, let's get started.
You deserve more than what I said.
Oh, thank you. Okay. So Shalini asked me to talk about oral cancers, and I think they've covered neoadjuvant chemotherapy. So I'm going to talk about adjuvant and metastatic or recurrent, and also touch a little bit about metronomic chemotherapy. So let me start off by talking about what systemic therapies, I'm sure you all know. So this is going to be the outline for my talk, a little bit about introduction and the necessity for guidelines and what are the guidelines that we have, a little bit about adjuvant therapy, and the most common drug that we use is platinum. How do we look at the optimal dosing? Then I'll touch about locally advanced, recurrent, and metastatic. I will talk about conventional chemotherapy, targeted therapy, and immunotherapy in this setting, and finally finish off with metronomic chemotherapy. So I think most of the people in the audience are surgeons, so I don't need to spend too much time on this by talking about what oral cavity is. But oral cancer as defined by AJCC and UICC and the TNM staging is that it is the squamous cell carcinomas that originate from the mucosal lip, anterior 2/3 of tongue, buccal mucosa, floor of mouth, hard palate, upper alveolus, and gingiva and retromolar trigone. Internationally, we have several guidelines that do exist today, like the NCCN, ESMO, and the Spanish Society. But all these applicable to the Indian scenario is questionable, because most of the people on these committees are from those countries, and they have no representation from India. and our oral cavity cancers are so much different. So I'm not sure if the whole thing can be applied to the Indian scenario. So with this in mind, a few of us got together and we brought out this Indian clinical practice consensus guidelines for management of head and neck cancers. And this was published this year in the Indian Journal of Cancer. I'm just showing you this for you to go and refer if you need. And this is a series of review articles, and that covers every site. And for today, this is the management of oral cancers. So let's go to adjuvant therapy. I'm sure you all understand what adjuvant therapy is that we give some sort of therapy after a good surgical resection is done. But in spite of a good surgical resection, many of these patients do come back with either local disease or distant recurrences. And that's what adjuvant systemic therapy is aimed at, to decrease these eventualities. So the indications are T3 or T4 tumor, compromised surgical resection that is less than 5 millimeters of the inked surface of specimen. This is from the NCCN guidelines. So what we did in our guidelines is that if the margins are positive, which according to the NCCN or ESMO guidelines is that they can be taken care of by RT. We have added that resection is the ideal thing to do when possible. But if that is not feasible, then concurrent chemoradiation is recommended. The other indications is lymphovascular invasion and or perineural invasion, positive lymph nodes with or without extracapsular invasion. I think this is generally the indications for adjuvant systemic therapy. Now, the most common regime that we use for chemoradiotherapy is cisplatinum at the doses that I've shown here. It's always a debate whether 3 weekly or weekly is better, and radiation is pretty standard. This is well established. And this, as shown here, is according to the Indian guidelines with the grade of recommendation and evidence level that is available. So what about platinum dose? Generally, cisplatinum is used, and only for those people who are not eligible for cisplatinum, we use carboplatin. This is a dictum that we do follow. And of course, today we have other options of some targeted agents, which I'll touch upon a little later on. So these are the studies to look at the right dose and schedule, and we have several of them. One of the studies is from India in 2016. And there's a meta-analysis talking about weekly chemoradiotherapy versus 3 weekly. And this meta-analysis of over 41 studies have shown that weekly chemoradiotherapy was very similar to 3 weekly with overall survival, but with lesser toxicity. So this is the forest plot for this meta-analysis of over 779 patients of 10 studies here. And again, showing you that it is in fact very similar with lesser toxicity. So after that, the ICMR brought out consensus document. This ICMR has been doing this for several tumors across the country, and they finished for about 24 tumors, and this is for the head and neck cancers. And here again, as you see, what they've recommended is 3 weekly cisplatinum or weekly cisplatinum. There's another paper which was published sometime back in JCO, again talking about weekly versus 3 weekly. And again, this has shown that it was in fact just as good to give weekly versus 3 weekly. And you see, as you see here, since we're talking about oral cavity, here 87% of patients in this study were in the oral cavity. And 93 patients here received in the adjuvant setting. This is our own paper from Kidwai, published last year, again talking about 3 weekly versus weekly. And again, we showed that the responses were very similar and the toxicity profile was slightly better in weekly. I think this was because when we gave cisplatin weekly, most of the times we medical oncologists review their parameters every week and see them. Whereas when it is done 3 weekly, they come to the medical oncologist only once in 3 weeks. So that may be a reason for better tolerance and lesser side effects in the weekly regime. So what is the way forward in adjuvant therapy? So for a long time, we have had platinum as the backbone with radiation. But now, this is a drug which is now being used in the adjuvant setting, a drug called nivolumab. And this is a study which is a phase 3 study. And as you see in this map, this is done across several countries. It's run out of Singapore. And this is the scheme of the study, that they want to recruit 710 patients who are resected stage 3 or stage 4. And they will be randomized to get their usual dose of chemoradiotherapy in 1 arm versus nivolumab plus chemoradiotherapy. And their endpoint is to look at DFS and OS at 2 years along with toxicity. And the last update was last year. They had recruited 219 patients. And I think it will be interesting to see what comes out of this study. The other one, which is actually ongoing now, is the immuno-oncology drug called atezolizumab, which is an anti-PD-L1 antibody. And this again is used in the adjuvant setting after they're in the high-risk patients, after they finish their definitive therapy for adjuvant. And this study is called WOKES. I'm not sure if many of you know who this person WOKES is. This is Dr. Everett Wokes from Chicago, who has done a lot of work in head cancers. And he has just been elected as the president of ASCO this year. I had happened to meet him last year because this particular study, the Wokes study, which is being done, he is one of the members on the data monitoring committee, and I'm heading this committee. So I'm fortunate to be there. And this study is going on well. It's recruited half the number of patients, and hopefully this will tell us that immuno-oncology will be useful in the adjuvant setting. So after that adjuvant, let's look at the locally advanced disease. In the locally advanced disease, cure rates we see typically are 20 to 50% because we have been able to improve the local control. And as I've told you earlier, it's a multimodal therapy that these patients need. And trade-off of this multimodal therapy is toxicity. And we are looking at decreasing the local recurrences and distant metastasis. But many times we do find that overall survival has not changed. So concurrent chemoradiotherapy is the standard of care. And this was published way back in 2003 in the NEJM. So this is sort of a summary slide showing you all the agents that have been tried in this setting, starting from mitomycin, 5-FU, carboplatin, with 5-FU and leucovorin. And this is with RT, induction chemotherapy followed by RT, or induction chemotherapy followed by CTRT. But the maximum survival in these studies is about 18 months. And that highlights the need for us to have some newer targeted agents in the disease management. So this is just to tell you that we have sort of plateaued off with the benefits that we see with chemotherapy, and we are looking at some newer targets. So this is where we are in locally advanced. And soon we understood, because of the developments in the molecular biology that we've understood, that EGFR signal transduction is a very important pathway in tumor cells. And as on date, this is the most validated pathway in several cancers studied today. And this is a slide just to tell you what the signaling is. We have these two EGFR receptors. This is the cell. This is a cell membrane. This receptor has an extracellular domain, a transmembrane domain, and an intracellular domain. And what happens is when a ligand binds, there's dimerization of these, which activates the intracellular tyrosine kinase, leading to the signals messengers that go to the DNA in the nucleus. And from there, we have secondary messengers that gives the tumor cell the advantage that it has in terms of increased proliferation, being resistant to the therapies that we give, having a survival advantage, producing angiogenesis and metastasis. So this we have understood well. And therefore, if we are able to block this, all the subsequent advantages that the tumor cell has can be taken care of. So like I said, chemoradiotherapy is the standard of care, and there is survival benefit to some patients only, and this is called for research. And in 2006, 2 of these targeted agents were approved, cetuximab being the first one, followed by nivolumab. So some data of cetuximab. This is one of the first phase 3 trials which combined cetuximab with radiation versus radiation alone. And this is the other one which combined chemotherapy with radiation versus chemotherapy plus cetuximab and radiation. What came out of this RTOG study was that the progression-free survival and the overall survival were very similar in the arms which had cetuximab or which did not have cetuximab. But more important, what came out was that adding cetuximab increased the number of adverse events. So whenever we add a new drug, we always bother about the new side effects that we add. And therefore, this was a significant proportion of patients having these adverse events. And therefore, they discontinued using cetuximab along with chemoradiotherapy, but it can still be used with radiotherapy. So this was the interim analysis, which I already told you. So then came nivolumab. I'm not sure about how much of history you know about this drug. This is a slide of Havana. I'm precisely putting this because this drug came out from there. The scientist there who is involved in this work is called Tanya, and this is a picture. And this is a molecule. This is a humanized monoclonal antibody with more than 95% of human sequences. An important thing, because of this, the side effect profile that it has is pretty low. Now, I'm sure you recognize this. This is the Mysore Palace. This is the Maharaja of Mysore. Why I'm showing you this is because this is a lady who's responsible for getting this molecule into India. Sadly enough, this molecule is not available in the rest of the world so easily. And therefore, we are fortunate enough that we have this molecule with us for the benefit of our patients. Now, whenever a new drug is being added, as I mentioned, we are bothered about side effects. So let me show you what is the toxicity of the EGFR blockers that we have seen till nivolumab came. That was cetuximab only. We used to see severe rashes like this. Diarrhea, I will not show any picture for that. Rashes used to be severe like this with superadded infection. Most of these women would develop brittle hair, inflammation of the nail bed, and conjunctivitis. So this is a slide to show you the toxicities of the two EGFR blockers, panitumumab, cetuximab, compared with nivolumab and erlotinib, which is sometimes being used. So if you look at the skin rash, it is in excess of 80% for panitumumab and cetuximab, whereas it is unidigit for nivolumab. The other important thing which many of us don't look at is the electrolyte disturbance. Hypomagnesemia is an important side effect which is not seen with nivolumab. This is again important because many times we combine this with platinum compounds, which by themselves produce hypokalemia. And if hypomagnesemia also sets in, it becomes a sort of hypokalemia that cannot be easily corrected. So this is a thing that we need to keep in mind, which many of us neglect actually. So this was the first study which was done with nivolumab in India called BEST. And this was way back in 2006 and 2008. And this is the scheme of the study. And this was the initial response assessment after 24 weeks after finishing the enrollment and the therapy for these patients. This is for the arm that got radiation plus nivolumab versus radiation alone. And as you can see, the response rates were 76% for those patients who got nivolumab versus 36% for those who did not get and who got radiation alone. Now, if you come to the arm that got chemoradiotherapy plus radiation, it was 100% for those who got nivolumab, whereas 70% for those who did not get nivolumab. Now we have actually a long-term follow-up of these patients, and this is the paper that was published talking about 5-year survival in these patients. And again, the long-term follow-up has not shown any new side effects. So this is a drug that we have for our patients here. Now, the other important thing that's coming up is the emerging role of HPV. And this is to show you that the survival of patients actually is dependent on HPV status. But an argument to this is that in the Indian setting, where most of the oral cavity cancers are because of tobacco use, whether HPV status has an independent prognostic factor or not. And most people today believe that when tobacco is the etiological agent, whether the patient is HPV positive or negative, it doesn't carry too much weight. So with that, let me move on to recurrent or metastatic disease. Surgery is an important part for selected cases. We all understand surgeons are the most important part here in head and neck cancers. We look at systemic chemotherapy, either single agents or platinum 5-FU as combination. And for a long time, cetuximab was the standard. This is the Western guidelines because they have not heard of nivolumab. And in highly symptomatic, this disease is highly symptomatic, and the median survival in most patients is 10 months. So this is a problem that we face with recurrent or metastatic disease. So this is the study which looked at combining cetuximab plus platinum and 5-FU in the first line recurrent or metastatic head and neck, and the primary endpoint was overall survival. And if you see here, there was an advantage of 3 months in the overall survival for these patients who got the chemotherapy plus cetuximab, and that it still has a role there. In our setting, we have actually started using nivolumab in place of cetuximab, as I showed you, because of its better toxicity profile and also the lower financial toxicity. The other drug that's been used is bevacizumab to target angiogenesis. And this is the advantage of adding bevacizumab, not very significant, but this drug is also there. Then moving on to immunotherapy, today this is the hot topic for most cancers, and it's crept into treating head and neck cancers as well. And this is sort of a summary slide talking about why immunotherapy is important. This is basically talking about the immunostatus in patients or people. What happens is the antigen presenting cell picks up a new antigen and presents that or the tumor cell to the activated T cell. And this activated T cell in turn produces more activated T cells which act on the tumor cell and brings about cell death. But the tumor has many substances that it produces to mask or suppress this immune surveillance in the patient. And this is to show you that if you look at TILs and head and neck squamous cell carcinomas, there is a positive correlation between TILs and the outcome in these patients. So we have drugs which block these pathways that are stopped by the tumor cell because of several drugs, cytokines that it produces. And this is to show you that this has an inhibitory action on the activated T cell to kill the tumor cell. But what the drugs that we use is the PD-L1 blockers. They block this pathway and prevent the tumor cell from suppressing the active.
Sir, we are unable to hear you. Govind Babu, sir? Yeah, I think Ratan sir, I think we seem to have lost Govind Babu.
Yeah, we lost the voice.
Yeah.
Maybe there is a connection problem.
Yes, probably. Yeah.
Yeah, definitely there is a connection problem.
Right.
Yeah.
Yeah.
I think we went off the air.
Yes. Bhargav, can you make sir the co-host quickly so that sir can start sharing screen?
Can you see now? No.
Not yet, sir.
Okay. Yeah.
Yes.
No, I think you can see. Okay. So this is the study called Checkmate. See, all these studies which use nivolumab are called Checkmate studies. And I'll come to the other one, which also has a name, acronym for their studies. So this is looking at nivolumab versus the standard of care for these patients. And this is the randomization 2:1. And if you see here, at 12 months, the overall survival was 34% for those patients who got nivolumab versus about 20% for the standard of care. And 18 months at 18 months, it was 21% versus 8%. And if you look at the outcomes in first line setting, it was even better. So it is important that we select our patients early and try and use this. This is looking at patients who had prior cetuximab. So by the time nivolumab came, many of these patients had had cetuximab as well. And if you see here, those patients who had cetuximab earlier did not do as well as those patients who did not receive cetuximab. And one of the mechanisms that has been told is that cetuximab has a mechanism of upregulating the Treg cells, which are preventing the immuno-oncology drugs from acting. And that is why cetuximab may not be an ideal thing to use in the first place. So people have looked at using this immuno-oncology drug beyond progression. Again, this is a small sample of 240 patients, but to show that use of this drug beyond progression may be beneficial for some patients. So this is a waterfall plot, again, to show you how much of benefit these patients have had. 20% of increase in target lesions at first progression was seen in 5 patients. So almost 24% patients had decrease in the target lesion. So this is the other drug, pembrolizumab. And again, this is in patients who had received cetuximab earlier. This is again showing you that almost 50% of these patients did benefit. So this is looking at overall survival, again, looking at HPV positive and negative patients. And this shows that those patients who are HPV positive are doing slightly better in terms of response to pembrolizumab. This is in the recurrent setting, looking at its role, showing you that there is almost 10% advantage of using pembrolizumab as compared to standard of care. So in this study, they looked at different subsets, seeing who would benefit. As you can see, almost every subset, there were more than 65 or less than 65, men or women, all of them did benefit. So looking at this now, they've started a phase 2 study looking at this in the neoadjuvant setting. I think Dr. Vijay Agarwal had discussed this earlier. So this is a promising way of looking at this drug as well. So today, immuno-oncology drugs are here to stay, and pembrolizumab has become an important agent in this field. So because of this, they've tried to look at combining with chemoradiotherapy, and this is a phase 1 trial of the same. And this is the schema of the study. And what came out of this study was that there was good response rates, and more important, the toxicity was not very high. Now, there are many other drugs that have come in, and this is sort of showing you all the combinations of these immunotherapy drugs with very many other drugs, looking at blocking several other pathways together, including drugs which are blocking the HDAC inhibitors, and including intratumoral injection of some of these drugs. And these are some very early studies, and we must wait and see what comes out of all these studies. So conclusions for the immune checkpoint inhibitors are they could be the new standard of care in this recurrent metastatic head and neck cancers. Second line at present, but first line I showed you one drug is approved. And the integration of these into curative intent is the way forward. Combination of these immunotherapy drugs seems pretty promising. So with that, let me go on to the other aspect which is important, especially in a country like ours and in the times that we are facing, like this pandemic. This is the metronomic chemotherapy. Metronome is a musical instrument that produces regular metric ticks, as I've shown you in this picture. And this is how the term metronomic chemotherapy came in. So the basis for this is that the chemotherapy or the cytotoxic drugs that we use here is in low dose, but they can produce death of cells and also arrest the cell turnover. They also have an effect on the endothelial cells in terms of decreasing the neoangiogenesis and it can upregulate the T cells, which I've shown you in the earlier cartoons with immunotherapy, that they can help in tumor cell kill. So this is just to show you how the balance exists in the normal human being, that the regulatory T cells and the effector T cells are balanced, whereas in suppressed immune response, the regulatory T cells take over. And by using either immunotherapy or metronomic chemotherapy, we are trying to bring this balance back. So this is how the metronomic chemotherapy is different from the classical chemotherapy that we give. Generally, we give chemotherapy in pulses every 3 weeks, whereas metronomic chemotherapy is given in very low doses, almost continuously without a break. And this is very nicely described in this Lancet Oncology paper way back in 2013. So if any of you are interested, you can go back to this and get full details on this. So this is to show you in brief what is the difference between conventional and metronomic. In conventional chemotherapy, we use what is called MTD, or the maximum tolerated dose, whereas in metronomic chemotherapy, it is very low dose that we use. As I already mentioned, this conventional chemotherapy is given at fixed intervals of 3 to 4 weeks. The gap is given so that the bone marrow recovery occurs. Whereas in metronomic chemotherapy, most of the times it is given daily. With the conventional chemotherapy, there's rise and fall of plasma concentration of these drugs. There's a big peak as soon as we give it, but rapidly it falls off. Whereas in metronomic, the drug dose is maintained in the plasma for a long period of time. And as we all know, chemotherapy specifically targets the tumor cells, which are rapidly dividing, whereas metronomic chemotherapy also has an effect on the endothelial cells of the vasculature of the tumor. Toxicity, we all know in conventional chemotherapy is a dreaded possibility, whereas in metronomic chemotherapy, because of the low doses that we give, toxicity is very, very less. And in many of these patients, we're looking at quality of life, which definitely can be maintained because of the lower toxicity. So this is one of the papers that was published from Tata Hospital. In fact, they've looked at adding erlotinib with the conventional metronomic chemotherapy that we generally give, which is a combination of methotrexate given weekly with cyclophosphamide given daily, along with celecoxib. So the celecoxib is given because we know there is overactivity of the COX-2 pathways in the tumors, and celecoxib can block this. And the other two drugs, as you know, are chemotherapy agents, which work on the tumor cells and the endothelium. This is one of the papers published very recently in this Clinical Cancer Investigation Journal. And this group is from AIMS, Delhi. And they've said that in this pandemic of corona, metronomic chemotherapy for head and neck cancers in a resource-constrained setting like India or any other country for that matter, this could be a very nice alternative to the chemotherapy that we give to many of our recurrent and metastatic head and neck cancers. So this decreases this, the number of visits to the hospital by the patient, and also since the toxicity is low, they can be monitored at home or even via video conferencing. So that is the role of metronomic chemotherapy today. And this is becoming important because of the problems that we have in our country. In fact, from Kidwai, when I was there, we had just finished 2 cohorts of head and neck cancer patients, of over 100 patients. And I think now there's a survival data of 2 years. So probably we'll see that paper soon. So to conclude, systemic therapy in oral cancers is now established as an important modality in its setting that I've shown you: adjuvant, locally advanced, recurrent or metastatic. And Dr. Vijay Agarwal has already discussed about neoadjuvant role there. And agents include conventional chemotherapy, targeted therapies, and immunotherapy, with several of newer class of drugs coming in and their combinations, which I've given you a few examples of. And metronomic chemotherapy, especially in resource-constrained regions like ours, could become an important role in treating especially recurrent and metastatic head and neck cancers. where many of these patients need to have an improved quality of life and not add on to toxicity for them. With that, I think that was the last slide, and thank you.
Thank you, sir, for an excellent talk. You explained the indications of adjuvant chemotherapy and other immunotherapeutic drugs succinctly. There are few questions from the audience, sir. Would
Yeah,
you
go
be able
ahead.
to take the questions now, sir?
Yeah.
Yeah. Sir, the question is, there is a question, what is the indication of immunotherapy? Is it recommended only in cetuximab and platinum refractory recurrent head and neck CA or upfront?
Right now, the approval is for second line for nivolumab in recurrent and metastatic. But for pembrolizumab, very recently, there is an approval that has come up in first line.
Yes, sir. And there's another question. I think she's not very well informed. It has been postulated that many adjuvant chemotherapy may not improve the patient's life. It will just add further to the financial burden, and after surgery, the patient can avoid it. Is there any chance of improvement of quality of life in such patients? Well, whether adjuvant therapy should actually be advocated to patients who have already gone through a lot during the course of cancer?
I'm not sure what this
Not based
question
on
means.
any evidence, sir. Would you like to
No,
take these questions?
I think I've given the indications for adjuvant therapy. So if there are any of those settings like T3, T4, or nodal nodes that are positive, perivascular invasion, perineural invasion, these are definite indications for adjuvant. And if she thinks that there is adding toxicity, then she needs to update herself.
Yeah, to the audience, please note that adding adjuvant chemoradiotherapy does add to the survival. It has a survival benefit. That's why it's all evidence based. It's not based on whims and fancies of certain surgeons or medical oncologists. Okay. Yes. And there's another question. So, what is the absolute benefit of using nivolumab or pembrolizumab when considering overall survival, toxicity profile, and expenditure?
We need to talk about expenditure or science. Of course, we need to link both. So, like I've shown you, there is an overall survival advantage even in recurrent and metastatic head and neck cancers with immunotherapy. As compared to the standard of care, there is almost 10% improvement at 2 years survival.
And that's quite a significant number.
Yeah. And it's important to remember that many of these responses are maintained for long periods of time, even after immunotherapy is stopped. So as on date, usually the immunotherapy is given for 2 years and then you stop. But
yeah, you should always give an option to the patient. If the patient can afford it, definitely
absolutely. Yeah. If they cannot afford, I've given you the other alternative of metronomic chemotherapy. I've seen many patients do well on that. But I think that is not for us to choose. We need to give the options to the patient.
The patient choose.
Of course.
Yes. As oral cavity cancer often does not express EGFR mutation, how do biological agents still remain effective? Another question.
Whoever asked this should go and read up. We are not talking about EGFR mutation at all in head and neck cancers. EGFR mutation is seen in other cancers, especially lung cancer. EGFR overexpression is what is important in head and neck cancers. And I didn't put that slide here because of lack of time. In fact, the EGFR overexpression is to almost extent of 100% in head and neck cancers. And we had done an exploratory analysis in our study of looking at EGFR overexpression and response to EGFR therapy. And we found that although the variation can be 1+ to 3+ on immunohistochemistry, there is no correlation between the higher the positivity, higher the response, or lower the positivity and lower the response. So in fact, what is recommended is you don't even look for EGFR expression. All these patients will definitely benefit with the EGFR blockage. So I need to correct this person who asked that we are not looking at mutations. We are just looking at blocking the EGFR pathway. Mutations are not important in head and neck cancers.
Yeah, thank you, sir. Well answered. Another question, is high expression of PD-1 mutation mandatory to consider immunotherapy?
No, that is only in the first line, and if you're using it as a single agent, most of these patients in the second line, they have looked at PD-L1 expression and correlation. Although there was little extra benefit in those people who express PD-L1, it was not significant. And there are studies to show that whether it is overexpressed or not, the responses can be very, very similar. And if you're combining it with chemotherapy, you really don't need to look at PD-L1 expression, because with chemotherapy, the responses are very good.
Yes. Thank you, sir. There is another question. What are your criteria for selecting oral cancer patients for adjuvant chemoradiation, adjuvant immunoradiotherapy with radiation, adjuvant chemo, and biological agent with RT?
So like I showed you, the two studies that have been published with biologics and chemoradiotherapy, the selection of patients was the same, that all those patients who would require chemoradiotherapy.
Yeah, all those with high adverse features. Yes.
High risk features. If somebody can afford to add on this targeted therapy, it is good. But if they cannot, then we don't. And the other thing is, most patients who require adjuvant therapy, it is chemoradiotherapy. For patients who are not fit to receive chemotherapy, the alternative we have is use a biologic instead of a platinum compound. So that is how we've been giving these drugs.
And the question, sir, is immunotherapy only recommended in cetuximab and platinum refractory recurrent head and neck cancer, or can it be used upfront?
No, right now the indication is not for upfront. It is only for the second line metastatic or recurrent. So that is what you must remember. Not as soon as they come, not the first line. In the first line, it is now only for pembrolizumab they have an approval, not for nivolumab.
Recurrent metastasis.
Yeah.
What is the standard regimen and dosing of metronomic chemotherapy? It's a good question, but
Yeah.
Sir, I would also like to add to that.
Yeah.
There's certain people who prescribe metronomic chemotherapy and even geftinib by themselves. So what do you say to that, sir?
So geftinib as a single drug has no role. I've been telling several people for several years, but they say, oh, in my series, when they say series, I think it is 3 or 4 cases. So they say it has shown excellent responses. But as a single agent, geftinib or erlotinib has no role. The paper which I showed was in combination with other metronomic chemotherapy, adding erlotinib. So the dose that I usually follow is cyclophosphamide 50 milligrams BD continuously, methotrexate 50 milligrams weekly, and celecoxib 400 milligrams twice a day. And every month I look at their parameters of CBC and LFT and accordingly monitor the drugs.
Blood profile, yes.
Yes.
Pardon me, sir, your voice is breaking.
Yeah. Now, can you hear me?
Yes, I think your voice has been clear.
Okay, thanks.
I think Dr. Ratan is facing.
Yes, sir.
Okay. Yeah, this is all network burdening. Too many webinars going at the same time.
And moreover, sir, metronomic chemotherapy is not holy water like anybody can prescribe it. You should always refer to a medical oncologist because it also has a side effect. Patient can have bone marrow suppression. Is it not, sir?
Yeah, I'm so glad you said that. Because I know many radiation oncologists and surgical oncologists just write and say, there's just a tablet, go, nothing will happen.
People think that it doesn't have any side effect. It does have side effects.
Yeah,
it's
absolutely.
Not holy water.
Absolutely.
You need to monitor the patient regularly.
Yeah. If they believed it was holy water, then they should have sent them to church.
And another question, sir, related to metronomic chemotherapy. What are the precautions to be taken for prescribing metronomic chemotherapy?
Precautions? Yeah. Like I said, the basic parameters should be within normal limits because although toxicity is low, we must remember that there is toxicity. Yeah, that's right.
Yes. Sir, another question related to the previous questions. What is the absolute benefit of using nivolumab over pembrolizumab when considering overall survival?
There is no head-to-head comparison.
And your another good question, sir, that you answered already, sir. Comparing nivolumab and pembrolizumab with regard to overall survival.
Yeah, there is no head-to-head comparison of these two drugs, and we'll never have a trial because nobody is going to fund this trial. So
there's another question, sir. What is your opinion on cellular immunotherapy and dendritic cell therapy?
These are still in clinical trials. People are left, right, center prescribing it, but there is no hard evidence to it. Although our drug control has approved of its use in India. But personally, I have not seen any great benefit from this for many patients who have gone to take this therapy. It's an important field that is upcoming. Yeah, go ahead.
Yeah. How much does metronomic therapy bring change in quality of life as it targets the endothelial cells?
Oh, it is definitely useful. It definitely brings about improvement in quality of life because, in fact, to tell you, one patient of head and neck cancer actually went into CR, and that was maintained for almost a year. That's a fantastic thing, I would say, and especially for head and neck cancers because of the local disease with infection, fungation, everything. It's a big social problem. So even if you're able to control all that, bring down the infection, bring down the fungation, I think it's a great thing that you're doing for them, and at a very low cost.
Done with all the questions, sir. Thanks for an excellent talk, sir.
Thank you very much.
Thoroughly enjoyed it.
Thank you.
Thank you, sir.
Thanks.
Thank you so much, Dr. Govind Babu sir and Dr. Ratan sir for joining us today. I think, this is a topic that most surgeons would like to know about, but don't find the time to kind of go into depths of, and we rely heavily on medical oncologists to help us when it comes to choosing the right, of course, the right way to treat patients who are, with advanced disease or recurrent disease. So thank you, sir, for throwing light on this topic. I think our audience was listened with rapt attention. Thank you, Dr. Ratan sir, for conducting this session so well. And I would also like to tell the audience that this webinar was streamed live on Facebook, and it will also be webcast on our YouTube channel, HCG Academics. So you can follow us there to receive live updates. Also, please join us next week for some more webinars on the oral module. Thank you, Dr. Govind Babu sir. And
Thank you so much.
Thank you.
Bye-bye. Bye.
Bye, sir. Thank you.